Today's topic for discussion is Anatomical Landmarks of Edentulous Maxilla in Complete Denture Prosthodontics. Before discussing the anatomical landmarks, we will have a brief description about bone and the lining mucosa. Bone is composed of outer cortical bone or the compact bone and inner cancellous or trabecular bone. The nature and the site of location of these bone determines the stress distribution. And coming to oral mucous membrane, it is composed of mucosa and submucosa. Okay, and depending upon the position and location of the different types of mucosa, it's classified as masticatory mucosa, lining mucosa, and specialized mucosa. Masticatory mucosa is present in the crest of the alveolar ridge and the hard palate. It is keratinized, and due to the presence of keratinized firm mucosa, these tissues permit better resistance to the stress. Whereas lining mucosa, it is present in the lips, cheeks, vestibular spaces, alveolar lingual sulcus, and soft palate, and it is non-keratinized, and whereas it is freely movable with the tissue. Specialized mucosa is seen in the dorsal surface of the tongue, and they are specialized for the taste sensations. Now coming to the anatomical landmarks of edentulous maxilla. The limiting structures are the structures which limit the extent of the complete denture. They include labial freedom, labial vestibule, buccal freedom, buccal vestibule, Hamlet notch, and postpalatal seal area. Coming to labial freedom. Labial freedom, it is a passive freedom. That means there is no muscle attachment. It is present in the midline of the maxillary edentulous arch. This labial freedom divides the labial vestibule into right and left halves. So coming to labial vestibule. Labial vestibule, as I have already told, it is divided into right and left halves by the labial freedom. Now this labial vestibule is under the action of orbicularis oris. Since the direction of orbicularis oris is in horizontal direction, the effect is indirect. It's not direct. So it will have an indirect effect over the impression and also over the denture base in the labial region. Coming to buccal freedom. Buccal freedom, it's a fold of mucous membrane which extends from the buccal mucous membrane into the crest of the ridge. So the buccal freedom forms a dividing line between the labial and the buccal vestibule. Now three muscles are attached to buccal freedom. They are levator anguli oris, the buccinator muscle which pulls it backward, orbicularis oris which pulls it forward. So because of the action of these three muscles, it has to be properly relieved during our impression making. Coming to buccal vestibule, it is the portion of the oral cavity that is bounded by teeth and gingiva and the alveolar ridge over the one side and lateral by the cheek and posteriorly by the which lie posterior to buccal vestibule. So the important aspect of buccal vestibule is that the size of the buccal vestibule changes by the action of buccinator muscle. When it contracts, the buccal vestibule varies. Size of the buccal vestibule varies. The amount of ridge resorption that has occurred in the maxilla also affect the size of the buccal vestibule, and also the position of the mandible also affects the size of the buccal vestibule. So this area has to be evaluated by asking the patient to make the lateral jaw movements. Now coronomaxillary space. This space is the region medial to the coronoid process and lateral to the maxillary tuberosity. So the boundaries of coronomaxillary space are anteriorly it is bound by the base of the zygomatic process, posterior by Hamlet notch, medially by maxillary tuberosity, laterally by coronoid process, inferiorly by the crest of the residual ridge. The clinical importance of coronomaxillary space is that it is primarily influenced by the coronoid process of the mandible. So patient should be asked to move the mandible to evaluate the coronomaxillary space. In some patients, the coronoid process flare laterally when it reaches its height. For these patients, while wide opening, it won't affect our denture. But in some patients, it might be straight and constricted medially. So while these patients, when they open their mandible, it results in the narrowing of the space and will affect the denture retention. Hamlet notch. The Hamlet notch is a displaceable tissue which is present between the maxillary tuberosity and the Hamlet process of the medial pterygoid plate. It's also known as pterygomaxillary notch. It also determines the posterior boundary of the maxillary denture. The importance of Hamlet notch is that this region provides the pterygomaxillary seal since it can be compressed. Now coming to postpalatal seal area. It is the soft tissue area at or beyond the junction of hard and soft palate on which pressure within physiological limit can be applied by the denture to aid in its retention. Now what are the advantages of posterior palatal seal area? Yes, it prevents the patient from gagging. The thickness of the PPS area counteracts the warpage. It provides retention obviously. It prevents food lodgement under the denture, and also it is sunken with the borders of the soft palate so that it will be less irritating to the tongue. Now what are the anatomical landmarks which support the maxillary denture or which provide support? They are the hard palate, residual alveolar ridge, rugae, the palatine rugae, and also the maxillary tuberosity, in which the horizontal slope of the hard palate and the crest of the alveolar ridge forms the primary stress-bearing area. Maxillary tuberosity and rugae forms the secondary stress-bearing area. Now the anatomical landmarks which has to be relieved in the maxillary region. They include the incisive papilla. Incisive papilla covers the incisive foramen, and beneath the incisive papilla it contains the incisive vessels and nerves. So this region has to be relieved. It also helps in the location of midline of the dental arch, and also fovea palatina also has to be relieved because they are the ductal opening, and it has to be relieved to prevent the continuous flow, or which helps in the continuous flow of saliva. Now the midpalatine raphe. Midpalatine raphe, there is extremely thin mucous membrane covering the midpalatine raphe, so it has to be relieved. And again, palatine torre, if it is present, it has to be also relieved.